welcoming all to join the session. And our first case will be presented Dr. Sai Satish from India, and he will discuss about the Mitral clip. Dr. Sai Satish, please.
Hi, hello. Thank you all
Yes.
for having me here. May I start?
Yes, you can start now.
First of all, I'd like to begin by saying that I really wish I could have actually been there to Bangladesh. I've never been there. I've always looked forward to coming. And I hope I can come in person next time. And I want to thank Professor Rahman and Professor Azam and all the organizers of the meeting for giving me this opportunity to be here with all of you. With that, since we are anyway running late, I'm quickly jumping into the presentation.
Looks good.
Perfect. So good evening, everyone. I'm going to engage you for the next 15 minutes on MitraClip. I'm going to start my timer here so I don't overshoot my time. There we go. So heart failure is a growing problem all over the world. It's estimated that about 26 million heart failure patients are there worldwide. We now have a 1 in 5 risk of developing heart failure in our lifetime. And this 26 million is the diagnosed cases. If you take the undiagnosed cases, it's expected to be almost 37 million cases. It's the #1 hospitalization globally, #1 cause of hospitalization, and over 50% of these patients are rehospitalized for symptoms within 6 months. So why is this an increasing? All roads lead to Rome. Increasing life expectancy, skyrocketing incidence of hypertension, obesity, diabetes, everything leads to heart failure in the end. And there are estimated about 4.6 million patients of heart failure in India alone. 30% die in hospitals and over 55% are readmitted, which I've just covered. Mitral regurgitation is a significant component in these heart failure patients' worsening outcomes. Now, we have two types of mitral regurgitation. We have the degenerative and the functional, or the primary and the secondary. So the primary is mainly caused because of damage to the leaflets, the subvalvular apparatus, and the cornea. And the secondary is because of cardiomyopathies that lead to annular dilatation, whether it's ischemic. Can you hear me well?
Can everyone please mute their mic apart from Dr. Sai Satish? There's a lot of background noise. Thank you. Azam bhai, I think the BSCI mic needs to be muted for the time being. Thanks.
Thank you so much. You can hear me clearly, right?
Yeah. Continue.
Okay, perfect. So there are two types of mitral regurgitation. You have the functional and you have the degenerative. So mitral valve disease is supposed to be 2 to 3 times that of aortic valve disease. And even in a country like America, about 1 million cases of aortic stenosis are diagnosed in a year. 14% are treated. 4 million cases of mitral regurgitation are diagnosed, and only 1.5% are treated. So there's a huge unmet clinical need to treat these. Now, what is the MitraClip procedure? The MitraClip facilitates the reconstruction of an insufficient mitral valve through tissue approximation. Basically, it's a modification of the Alfieri stitch, a mechanical solution to a mechanical problem. And this creates a tissue bridge which heals and which looks like the specimen I've just showed you. So I'm not going to go into data because we don't have the time, but to very quickly talk about just 2 studies. It was first case in man was Everest feasibility, 55 cases in 2003. The landmark trial will be the COAP trial, and some expand data has just been presented recently. So what did we learn from the COAP trial? The COAP trial was predominantly for secondary MR. The first thing we realized is that the MitraClip was safe. There was a durable reduction in MR. There was a reduction in the rate of heart failure hospitalizations, improved survival, quality of life, and functional capacity up to 24-month follow-up. The MitraClip was the first therapy shown to improve prognosis of patients with heart failure by just reducing death. What did the EXPAND do? While that was only for FMR, the EXPAND had 2 groups, DMR and FMR. And what they realized is even the DMR patients performed as well as the FMR patients. And not only that, the results were reproducible, consistent, and sustained. They were actually similar or even better to what was achieved in the COAP trial. So with this, I'm going to show you a few cases that I did over the last couple of months. This is an 86-year-old gentleman, diabetic and hypertensive, coronary artery disease, had an acute coronary syndrome, ad hoc primary PCI to left main and circumflex. Severe MR with a flail P2, more towards P3, cardiogenic shock, lactate climbing, liver enzymes climbing, low cardiac output, creatinine 1.9, unable to come off a balloon pump, unable to come off the ventilator, was shifted by hospital. And here's a screenshot of the patient saying that I'm from Bangalore. This is my father. I'm sure my doctors would have briefed you. We are not able to come off the balloon pump. And this is what happens when you have acute MR. Unless you fix it, patient is not going to improve. They could not get off the balloon. They could not get off the pressors. He was in metabolic acidosis because of low cardiac output and he was sinking. So rushed him over an ambulance. You can clearly see the overriding P2, right? So you can clearly see the overriding P2 here and the torrential eccentric jet it's producing. Wide jet, the mitral valve area was large enough, almost 5.82 centimeters. Anything under 4 centimeters, I'm still worried about stenosis while clipping, but 4 centimeters and above is a good, comfortable thing. So the problem you have when you have acute MRs is when you have chronic MRs, which are the FMRs, the LA has time to enlarge. When you have an acute MR, like you have an acute infarction and a papillary muscle rupture and then a chorda flail and overriding, the LA does not have the time to enlarge. So two things happen. One, your LA pressures go up very high because of the torrential MR. Second, the LA is so small that normally for mitral clip, I have to take a mid fossa puncture. But if you can see here, I had to go so high up, even though the fossa was here, because I need at least 3.5 centimeter height to be able to maneuver inside the LA and clip the valve. So this is a little risky. It's a challenging case, but there was no other way to save the patient. Now you can see that after I've put one pigtail in the LA, this is the balloon pump. As I enter the LA, even before I can fully enter the LA, I'm already in the superior pulmonary vein. So now I have no choice. I can't even have my mitral clip guide catheter in the LA. I have to actually keep it in the RA. And the problem with keeping the guide catheter in the RA is one entire motion of antro-posterior while you're doing the clip is from the guide catheter. And that motion you have to sacrifice. So just keep watching this. You can see how I'm pulling back and you can see the clip fall from the superior pulmonary vein into the LA. Did you see that? So once the clip has fallen, you can see it's free of the Coumadin ridge. It's right over the mitral valve. Then I start tilting the clip in place. I go to 3D and fast. I align it exactly perpendicular to where I want to clip it. The guide catheters in the RA. I'm using only the clip system for maneuverability. And here you can see a beautiful image of the clip arms and both the leaflets exactly where the P2 is flailed, tapping onto the clip arms. And the key here is to find the right time when both leaflets are on the arms and put the grippers down. Here you can see the leaflet jumping nice and high, and you can see the motion is restricted because both are trapped by the grippers. Once I know I have a good grasp, I close the clip, I check the color, I'm perfectly where the jet is. And the minute I close, you can see the MR has disappeared. So this is a picture of the clip closing. So what I've done is I've taken echo and fluoro, because it took me some time to be able to adapt myself to just doing echo. Normally, nowadays, I don't even fluoro, very rarely, just to see where the clip arms are if I need to. But for you to understand, I just showed you how it looks on the echo and how it looks on the fluoro. And this is predominantly a fluoro-guided procedure. I mean, an echo-guided procedure. So you can see the clip released, and you can see the MR is almost completely gone. You can see that post-procedure mean gradient is only 2. Look at these. The LA V waves were at 40 and down to 13. So instantly the LA pressure comes down. This is the patient after being 8 days on a ventilator, balloon pump, and this is a patient 1 week post-procedure playing with his great-grandchild. The next patient I'd like to show you is a FMR with cardiogenic shock. So first, now I showed you a degenerative or a flail P2. Now I'll show you a functional MR and cardiogenic shock. 72-year-old male, diabetic, hypothyroid, CAD, old antral MI, PCI in 2005, severe biventricular dysfunction, 25% EF, severe MR, functional, worsening on medication, creatinine again shutting down, kidney shutting down, liver derangement in the thousands, lactate high. This patient was shifted by air ambulance. Even during the pandemic, they tried their best. They jumped on a couple of planes. By the time they reached me, his pressure was 80/50. By the time they gave the GA, his pressure was systolic 60. My anesthetist was wondering, is there even a point going and attempting this case? Because this was the LV. Now, the serious worry in the cath lab is that with such a bad LV, the minute I clip the mitral valve, will the LV tolerate the afterload? Will this patient just collapse? Because it's hardly 20-25%. Am I going too fast? Can you all hear me clearly?
It's okay. It's okay.
Thank you. Doing very well.
So you can see how bad the LV is, and you can see the torrential MR and the ballooned out LV and the huge gap. So very quickly went in, took the puncture, got 2 wires in. got one clip in. You can see in 3D NFAS how the clip is beautifully aligned towards the part of the biggest hole. Left the first clip. Now, my initial strategy here was to do just one clip and reduce the MR enough to get the patient stable, because I was not sure if I clipped everything out, the patient would improve. But the minute I put one clip, my anesthetist is like, sir, what did you do? Whatever you did, please do it, because his blood pressure is just shot up from 70 systolic. I'm on all pressors. Now his blood pressure is 120/80. I'm actually going to come down on pressors. So I became a little more confident, took the second clip, took it nice and tight close to the next clip. And you can see here how one clip is in place and the second clip is bisecting the jet right above. The big gap, the hole is seen here, and you can see the two clips in place. And we got an excellent reduction MR from torrential MR to just a trace. Look at these LA pressures. A V wave of 84 after one clip came down to 55, and after the second clip came down to 26. Look at his lactate. Pre-procedure lactate was 9, post-procedure 1.36. This is how his monitor looked post-procedure. CVP was 36. It was down to 6. Heart rate is down to 69. Saturation is 100. Pressures are 130/70 with minimal supports. As you can see, over the next 3 to 4 days, his creatinine completely normalized. His LFT is completely normalized. This was the patient 12 hours after procedure. This was the patient 36 hours post-procedure. Oh, I'm at 9 minutes, so I still have some time. So 80-year-old male, hypertensive, azotemia, creatinine 2.5, acute MI, severe LV dysfunction, post-cardiac arrest survivor, multiple hospitalizations, refractory heart failure. Again, we go in, one clip. Look at the huge gap of non-cooptation. And look at the wide jet that's there. So we go in, you can see the huge gap again. And these are these huge gaps that are really tricky because you don't know if you'll get enough of that posterior leaflet in for the clip to be stable. So went in, put one clip, you can see the transgastric view, the clip beautifully in place, the gradient is only 2. V wave from 86 down to 31. And this patient just blossomed. Every 2 months, he sends me a message saying, good morning, sir, thank you for the miracle. He wrote a message saying that, I've never seen my father lie flat in the last 5 to 6 months. And every morning, 5 o'clock, I used to have a coffee with him. And I just wrote back saying, I'm happy, that's a good thing to miss. And this was the other patient. So he's 3 years down, he's still doing well. Last case, and then I'll wrap up. This is an 80-year-old male, lateral wall MI in 2016, occluded RI, attempted and failed, ruptured papillary muscle, severe MR. This patient was required twice a month hospitalization, was bedridden because of heart failure.
So in 2016, when my dad had a heart attack, he was obviously put on certain medications. And we were using those medications for a while. And after about a year, his ability to walk was decreasing. His physical ability to just sit and concentrate or do his own things was getting limited. More so in the last 8 to 10 months, when he was not able to go use the restroom on his own, is when things started really going south. He started having pulmonary edema, which would make his legs swell, and the liquid in the lungs was making him breathless. So I think Mitral clip was really a magic for us. And this whole process and the procedure was a miracle. We are really hopeful that with the combination of reduction of the medication and physiotherapy, he can regain some of his mobility back and enjoy his life. Maybe take short walks outside and just the wind in his face.
So this gentleman was so sick when he came to me that all the daughter wanted was him to be able to sit in the garden. Now, even my team was doubtful, saying that, is there any point in doing a mitral clip on an 86-year-old bedridden patient? But just 1 month later, he's watching television. 6 months later, he's standing up and sitting. And 6 months later, he's walking around in the garden, a complete transformation. And now 3 years later, the only fights he's got with his family is that he's scared of COVID. He doesn't want to drive and he wants to drive on his own. Thank you so much for the patient hearing. And
Thank
I
you.
think I
Thank
finished.
you, Dr. Satish, for his nice deliberation. Mitral is maybe the magic for some patients, but in still we are not starting in our country. Hopefully, we will start soon. The participant may have any question to the Dr. Satish. You may ask directly or in the chat box.
Hi, this is
Thank you, Dr.
Nasser Khan from USA. I would like to congratulate Dr. Sai Satish for starting this MitraClip in India. These are fascinating cases. I have one comment and one question. The comment is that I completely agree with the changes. You know, I started the MitraClip program in our hospital, in Central Iowa. So the fascinating part was, before I started, I didn't realize the patient satisfaction, just like you mentioned. Like when they come back to see you, how good they feel. I didn't realize that it was make such a difference in their lives. They tell me the exact same things that they tell you, that, you know, I can do so much, and, you know, I can walk and I'm not short of breath anymore. I mean, that's a huge satisfaction as a you know, treating physician. That's my comment. My question is, the challenge that we face is, like you mentioned, you are heavily dependent on transesophageal echo, and echo is really your eyes. And, you know, a MitraClip procedure could be an hour procedure, but it could be sometimes a 4-hour procedure. So the TEE person has to be very patient person, you know, working with you, and has to know the exact frames and the exact images you are wanting. And that sometimes becomes a challenge for us. So how do you overcome that challenge and get a partner or colleague, like, you know, with that mentality?
So the thing is that Dr. Khan, first of all, it's a pleasure. Thank you for the compliment, but you're absolutely spot on. The way the patient improves is predominantly, I think, because of the drastic reduction in the LA pressures, that instantly they can lie flat. They feel like their lungs are free. And even if the MR reduction is a little more than what you expected, they still do beautifully well and they keep coming back. Now, this is a predominantly TE guided procedure. And you know that we're useless without the views in the TE. And every patient is different, because when they do the screening TEs, they're lying on the side. Here they're lying flat under GA. Sometimes to get that view where you have to see the clip arms, right? And you have to see the clip arms. So you know what? I struggled a lot for my first 10, 15 cases. Now I have a simple thing I tell my TE guy. So he's a cardiac anesthetist, and I have Professor Chandra from Mayo Clinic, who keeps visiting us from Rochester, who's absolutely brilliant. When he's in the lab, I just go and have fun, because whatever I want to see, he'll show me, right? But when I have to operate with a less familiar, with an echocardiographer who's less familiar, I say, first, give me bicable. I look at bicable, I just see where I am in my fossa. Then I don't even ask him to go short axis. I just say, explain it. He explains it, and then all I have to do is see if I'm posterior enough. So my puncture is done, right? The next thing I do is, I tell him, you find the view where the jet and the flail is maximum. And you keep your probe there, I will come to you. Which makes life so much easier, because if he starts chasing my clip, between him and me, we are lost in the LA. So now what I do, when depending on the view he's in, whether he's on bicommissural or whether he's on short axis or base, I just decide whether I have to move anterior, posterior, or go lateral, medial. So when he's in bicommissural,
Good thought, because we are it is time constraint.
Sure. So it is just echo guided, and I just have adapted to a way where I tell him, you find where you need to clip, I'll come to you, and I get to it and clip him.
I have a short question to Sai Satish. I am Dr. Momen from NICBD. What is the ideal puncture site for MitraClip?
The ideal puncture site is, you got to get superior and posterior. So that is where you got to aim for. And if you get 3.5 centimeters, you're comfortable. But the more you get, the more comfortable you'll be.
Thank you.
Dr. Sai Satish, thank you for your excellent presentation. For the interest of time, I think we shall move to the next presentation.